welcome to another installment of our ongoing virtual series, Alumni Conversations. My name is Jennifer Naney, Director of Alumni Relations, and today we are speaking with TCOM alumna, Dr. Helene Alphonso. Dr. Alphonso is a fellow of the American Psychiatric Association, sorry, I need my glasses, and boarded by the ABNP as well as the ACONP. She graduated with honors in neuroscience as an undergraduate and attended Texas College of Osteopathic Medicine. Dr. Alphonso practices as an attending psychiatrist at John Peter Smith Hospital in Fort Worth, Texas for their psychiatric residency program and as a consultant to the Neuroscience Institute at the University of North Texas Health Science Center. She has previously served as the Director of Medical Education for Texas College of Osteopathic Medicine Residencies, Director of Osteopathic Medical Education at JPS, and Osteopathic Program Director of Psychiatry at JPS. So thank you for being here today, Dr. Alphonso.
Thank you so much.
So for time, let's just go ahead and get started. Why did you choose the Health Science Center as the place to pursue your medical degree?
So I'm actually going to start from the beginning as to my psychiatry journey. My whole life, I had planned to become a dentist. And when I was doing my pre-dental studies, I stumbled upon a couple of neuroscience courses. And I just thought it was the most amazing thing ever. I felt like neuroscience was just the answer to the universe and understanding humanity. I started learning, okay, so people with this neuroscience degree can go into research, you can do therapy, or you can prescribe medications. And I said, well, you know what, I want to be able to do all this neuroscience stuff with the medications. I said, oh, so you have to go to medical school. And I said, okay. So as I was in my undergraduate pre-med committee and I told them, I said, well, I've done neuroscience and I've been told that if I want to prescribe medicine, I have to go to medical school. And they laughed me out of the room. They actually were like, what? Nobody goes to medical school to be a psychiatrist. You can't tell people that. So I rewrote my personal statement. I kind of came up with stock answers. So while I was interviewing at all these other medical schools, they're like, oh, so what are you interested in? And I'm like, oh, anything. But when I came to TCOM, I think they were just genuinely interested in improving the lives of the patients. And they were really looking for like-minded, holistic minds that were sort of like my interviewers. And I actually told them the truth. I said, you know what, I actually really want to be a psychiatrist. And they said, you know what, I think that would actually be a good fit for you. And I chose TCOM because I felt like this was where I belonged. I also felt like the osteopathic profession is just so melded with psychiatry, because if you are properly treating your patients, you have to look at it in a holistic way. And I have seen that reiterated and reinforced in training residents as well.
That's wonderful. And I'm glad that you knew going into medical school kind of what you wanted to do. And as you progressed throughout your medical school career, you continued to stay with it. Did at any point in time your interest in psychiatry waver while you were a med student, or were you pretty set on it like you were going into it?
I was pretty set. You know, I think even in my careers before I went to medical school, I worked retail, I sold health insurance, I did all kinds of things, and I felt like I was always doing therapy. When I was on my OB rotation, I was always doing therapy. I kind of didn't matter what I was doing. So you know, I thought OB was actually a lot of fun. I liked neurology, but I was just kind of saddened with neurology. It's like nobody gets better. So I figured that wouldn't be a good fit for me. But I think I was always kind of doing psych no matter what rotation I was on.
Yeah, I think that's great. And I love that you went into it knowing, and it kind of progressed even more as you progressed throughout your career. So switching gears just a little bit, you are a faculty member for the Psychiatric Residency Program at JPS in Fort Worth. Can you highlight some of the features of that program and talk to us a little bit about your role within the program?
So my office is very diverse. About a third of my patients have insurance and are basically kind of like just regular patients you would see anywhere. A third of my patients have Medicaid or Medicare. I treat a lot of patients who are actually in group homes, some of which are nonverbal with profound intellectual disabilities. And then I have a third of patients who are uninsured. And so my clinic is sort of a snapshot for my third-year residents of anything you could possibly come across in the outpatient setting. So it's definitely never boring. I also work with on the inpatient unit. I still take a call on the inpatient unit. So that's where I get to work with the first and second year residents. And that's also where I get to meet the TCOM medical students.
Awesome. Well, hopefully you have enjoyed your time working with them, because I know they probably enjoy their time working with you. So the next question, you still work obviously very closely with the Health Science Center through your consultant role to the Neuroscience Institute and also through the residency program as you just described. How important is it for you to be a part of current TCOM students' medical school and their residency journeys?
So I really feel that being part of TCOM has really made me hone my craft. I always have to know, wait, why am I making this choice? What were the articles that led me to this choice? What is the neuroscientific basis of this decision that I'm making? I think if I were not teaching and didn't have the relationship with TCOM, I could just sort of get in the rote of, okay, patient has this problem, you do this thing. And we have a lot of fun. We bounce the ideas off of each other. Sometimes residents will suddenly say something. I'm like, oh, I never thought of that. And I really think the patients get a better level of care because of that sort of dialogue than they would if it was just me not teaching.
Yeah, I agree. So what advice would you give to current TCOM students about their time in medical school and residency?
So in residency, I started making a cheat sheet. So basically when I would look something up, now of course the internet was not big when I was in medical school, like it was still brand new. And so I used a book called 5-Minute Consult to look things up. But I couldn't assimilate that information. I couldn't make it my own. So I sort of created like my summary of medicine according to Dr. Alphonso. I basically would write down a few sentences about that condition that was in my own words, and I sort of started creating that. And for me, that really helped me when it came to boards or just when it came to remembering, because I'm not one of those people who remembers by just reading it and then it sticks there. I had to sort of make it mine. So I started that in residency, and I think I should have started that in med school.
I think that's good advice, especially I learned the exact same way. So, and there's so much information coming at you so fast with your medical school and residency. So I think writing it down, making a cheat sheet is a great piece of advice. So do you have any specific advice for students who may be interested in pursuing a psychiatry specialty?
So definitely, I'm going to say maybe don't watch movies about psychiatry because they just depress me. I mean, like they never get it right. So movies are not accurate, but start reading books. Read books written by therapists and psychologists. Read books. You don't have to necessarily lead, Freud and his dream analyses, but kind of learn some of the themes that happen in psychology. And I think it would actually be a really good idea to read the big book of AA that's used for 12-step programs. We will sort of go over psychology theory in residency. We will sort of go over the 12 steps, but these are things that you will sort of be extra tools for you to draw upon when you're a resident. And you just don't have the time really to do all that kind of reading. So start doing the reading now and sort of assimilating that information early.
Yeah, I think reading, anything you can get your hands on reading wise is great. So I know that right now, with COVID, things have kind of changed a little bit. So can you walk us through maybe some of the most difficult challenges you have faced as a psychiatrist, both pre-COVID and post-COVID?
So pre-COVID, I'm going to say really navigating the systems and the quite lean social services that we have in Texas for patients. People who are suffering from mental health are dealing with trauma, they're dealing with hallucinations, they're dealing with a lot of things that prevent them from being able to sign up for food stamps, do kind of basic things that other people are better able to do. And I have to be an advocate for my patients. When I realize, you know what, I think this person has food insecurity, I just pull out the food stamp form. I say, here you go, here's the doctor's form for you to get food stamps, take this to the office. I can't wait for them to ask for what they need, because sometimes because of their disease, they just can't, or sometimes somebody who's so depressed, they're not going to be thinking about those things. So it's my job to think about those things for them. So I end up doing a whole lot of social work, but also because sometimes for somebody who maybe has paranoia or psychosis, they're not going to trust me to say, okay, I want you to go talk to the social worker who's somebody that you don't know. You know, they don't feel comfortable to do that, but they feel comfortable with me. So I take it on myself to do that in my residence.
I think that's wonderful. And I think that kind of goes back to, TCOM's whole philosophy of, a holistic approach to medicine. You're not just going by the book, you're looking at all the other facets that could be causing that problem. So
absolutely.
So we are through our questions that we came up with as an alumni relations office, but we have a lot of questions from students. So if you are okay with it, we can go ahead and dive right in.
Let's do it.
We did have one come through the chat, and I did want to mention this one. I thought this was great, but what are the pros and cons of inpatient versus outpatient psychiatry? And which setting do you prefer to practice in?
So inpatient, your decision making is less. Basically with inpatient, your decision is keep the patient in the hospital longer, change something with their treatment, or discharge the patient. So your focus is sort of like, okay, what do I need to do to get to that next step? With inpatient, you're kind of going to see everybody at their worst. And so you can have the opportunity to see dramatic improvement in a short period of time. But then you also don't get to see them really achieve their full potential, because once a patient is fully in recovery, you're not going to see them in inpatient anymore. In inpatient, sometimes it's a little more flexible, because you could maybe see all your patients in the morning, do all of your notes in the afternoon. For the students who have rotated with us at JPS, you know that we are also expert witnesses and we testify in court, and that is an amazing experience in inpatient. I kind of liked it. I thought testifying in court was kind of fun, so if that's sort of your thing, then you get to do that. With outpatient, I do like that I get to really make long-term relationships with my patients. I get to cheer for them when things improve, and when things aren't going well, I just hold their hand through the process. Hours, I would say outpatient, you're pretty, you're there 8 to 5. It's a full day. With inpatient, sometimes you might be able to finish up a little early, but then of course you might do some more teaching. So it's different flavors, and I really don't think anybody can say for sure, oh, this is the only thing I want to do. A lot of psychiatrists will do a combination of inpatient in the morning and then outpatient in their afternoons. So it just kind of depends, where you fit best and what you decide to do. And you might change your mind later.
Yeah. Sounds like you have options, though, to keep it different. And I think that's great. So being an attending psychiatrist as well as a consultant to the Neuroscience Institute, how do you experience an overlap between kind of the two specialties?
So I'm very fortunate. I kind of always go into everything somewhat neuroscience minded. I think of diseases as, okay, what's the neurochemical process here? In the Neuroscience Institute, my research is mostly on Parkinson's and traumatic brain injury. And those are things where I do have a lot of overlap in my clinic. I do feel I might have caught some Parkinson's cases maybe earlier than another psychiatrist would have had I not been doing my Parkinson's research. We even found there is a psychiatric medication that's used to treat side effects of antipsychotics that causes Parkinsonism. And we actually did a case study. And because I knew all the Parkinson's screening tools and the Parkinson's rating tools, we were able to really have a more fleshed out research study on that than really what other psychiatrists have had. And definitely, I think that they both work very hand in hand to make me a better clinician and diagnostician.
I bet he does. So having an osteopathic medical education, would you say you have had any differences in your approach or practice to psychiatry?
So I sort of took this for granted. It's interesting. I do have a lot of osteopathic-minded allopathic residents who choose to rotate with me. Sometimes I would have a resident that I was training and I'm like, why are they just so focused on, oh, the patient couldn't sleep, so I gave them a sleeping pill. I'm like, okay, yes, you give them a sleeping pill, but I was like, so why weren't they sleeping? Did something change? Did something happen in their life? And I guess I kind of took for granted my osteopathic residents would just ask all those things right away. And some of my allopathic residents, I sort of had to train into doing that. Like it wasn't just pre-programmed. So that was kind of an interesting thing that I found. I do try to sort of say, especially if somebody starts using drugs at a certain age, I'll say, well, what was going on in your life at that time? You know, and sometimes it's, oh, well, you know, there was maybe a divorce or a death or, you know, maybe some serious sexual trauma. I do tend to run over. I kind of have a reputation that I take a little bit longer, but I think sometimes that digging is really worthwhile instead of just saying, okay, here's your pill and move on.
Absolutely. I think it definitely changes your overall patient interaction. And I think at the end of the day, the patient's better off having,
I hope so. Yeah.
having that run over. So we noticed, you know, of course, you're the osteopathic program director of psychiatry at JPS. How is it different than being a non-osteopathic program director?
So now we have sort of integrated those roles because we do not have the separate track any longer. But I will say, I think I might have had higher expectations. I think some of my osteopathic residents thought I was kind of hard. I expected more. And I kind of expected a degree of self-actualization and growth throughout their education that I would sort of expect. So I think that was the difference. I think I just kind of held them to a different standard maybe than the allopathic director did.
Yeah. And having experience seeing how psychiatry residency programs look at applicants, would you say there is a discrepancy at how programs look at DO students versus MD students?
So I am a little myopic when it comes to this because I am part of a very DO-friendly allopathic program. There are times when every single intern we have is a DO. I will say that I think our allopathic counterparts, definitely at UT Southwestern, have been just gobbling up our DO applicants to their fellowship programs. And I think they definitely recognize that the holistic approach, the work ethic, and the patient connection that is definitely needed in psychiatry is something that I think they do value. So I do think the good thing about being a DO in psychiatry is that I think you might face less discrimination than maybe other traditional programs. Now keep in mind, I graduated from TCOM in 2004, so it's been a little bit since I've had to do that application process. But in speaking, just even with like at the consulate liaison national meetings, you know, speaking with allopathic program directors, I don't think they really, I don't see a lot of discrimination happening, and we really have our predecessors to thank for that.
Absolutely. And that's great that you don't experience that, and that the students or the residents now coming through don't experience that there. So overall, what would you say is the most rewarding part about your career?
Definitely having a patient who was living their best life and just knowing that I was a small part of that. Having them say, you know what, I got my son back and now my family's reunited, or say, you know what, I've kept a job now for 4 years. And, you know, the patients know, I think, you know, I'm a pretty kind of open, bubbly person. I think they know when I'm excited, and that, you know, that they sometimes come to me like, hey, guess what, Dr. A, I did this, and know that I genuinely am cheering for them. I can definitely say that, you know, I'm a stop along the journey, but not the whole journey.
Okay, we have a few more questions. And one of the questions was, what are some of the most challenging parts of your job and how do you cope with those?
So I do have a handful of other psychiatry friends, and just friends that are not psychiatrists too, when I'm getting too much in my head. And we call it, sometimes I'll say, hey, I need some supervision on this. And, I'm so fortunate at JPS that I work with such a great team, and we are a team. I saw Dr. Deerdorf was on there. She was part of our team too. It was so good to see her. So you have to be humble as a psychiatrist. You have to accept that you're going to have limitations, and there's some things that maybe hit too close to home, and definitely, especially with COVID, I do have to keep up with my exercise. If I miss my exercise, I start getting stressed and not sleeping. So the self-care definitely has come in. I will say I took advantage. Headspace has offered a free Headspace for the rest of the year for anybody who was, working on the front lines. And basically our clinic we've been working all the way through COVID. So I will say Headspace, the meditation app, has been really helpful for me.
Good. And that kind of transitions to another question that was brought in. How do you manage work-life balance? Being a mother, being a wife, being, a full-time employee, how do you do it all?
So I have to switch gears 100%. I can't be mid-gear. So basically when I'm at work, I am 110, 150% at work. I can't be, my family knows, like, you don't call me at work, I'm all in. But then when I'm at home, I'm all in at home too. And I have chosen to work part-time. I'm blessed that JPS has still found value in me, that, I can still be part-time. But for me, I needed that, so that way I could be there for my kids. Earlier, I was also a caretaker for my grandmother who had dementia, and she was 96 when she passed away, but I was able to be there and be able to help her, during that time in her life too. So I made that choice to be part-time. So my saying is, you can do anything as long as you're willing to take a pay cut.
Yeah. I think that's great advice though, because life comes at you pretty fast, and you got to make adjustments where you can. So for people who are interested in the JPS psychiatry program specifically, what exactly are they looking for in an applicant? How important are their step 1 scores, their class ranking, research experience, any of that?
So we've never kicked anybody out for class ranking. I don't think we really weigh that as high. For step scores, we definitely want to be sure that they can pass their step 3. So, that is important, because you will take your step 3 when you're an intern, and that's a challenging time. But we would rather have somebody who is a team player, who demonstrates compassion and kind of has a high EQ, emotional IQ, and we won't dismiss people really for, I guess, scores on tests or class ranking.
And since you have served as the Director of Medical Education for the Texas College of Osteopathic Medicine residencies, do you have any opinions on the future resident applicants who have done psych online rotations?
I haven't even thought about that. So I think right now, in the way the world is, I do think all programs have a degree of acceptance that an online experience of a rotation is definitely not the same as in person. And so is it going to count against you personally? No, because everybody else was all in the same boat. I do think it's going to make the first couple weeks of intern year more of a challenge, because when you're a med student, you sort of have a chance to kind of learn some of the nuts and bolts of medical practice is really workflow, keeping lists, where do you find these kinds of things in a chart? You're going to have to find that in your intern year. But I definitely think programs get it. They know, and they know they've also been flying by the seat of their pants just to kind of come up with something. So it's not going to work against you, thank goodness.
That's good. I'm sure that is a sigh of relief to some people. So, I know earlier you had mentioned some changes a little bit with COVID-19. Y'all still were working throughout. Did telemedicine impact your role at all, or has it, or do you see a future of telemedicine in your role as a psychiatrist?
So I was fortunate that I was doing some telemedicine before, so I had some experience. I knew kind of some of the staging aspects of telemedicine, and the eye contact thing is really just throws you off like crazy. So I had learned some of that ahead of time, which was good. It is harder to connect with patients. Our suicide rates in psychiatry, I think the consult service is quadrupled in the number of people attempting suicide. I do think some of the detachment that people experience when they're not really there with their physician. We are offering telemedicine at JPS from now on. I have a lot of graduates who have gone into just all telemedicine all the time. So the good thing is definitely now our residents are all getting training in that, because at this point we're having patients in the office and then also having patients on telemedicine. And so as a training institution, I think our residents are really going to be in a much better position because they're getting that experience. But as I said, for some patients, it adds a degree of detachment that isn't always good, and it's not a good fit for everyone.
That's good to know though. Well, that was all the questions that I had. I don't know if we have a few more students still on the call. Did y'all have any other questions that y'all would like to ask while Dr. Alphonso is here? Okay. Well, if anyone has any additional questions that they would later like to ask, please feel free to email alumni@unthsc.edu. And I think that is all the questions that we have today on our end, but we just wanted to say thank you so much for your time today. It was great to see you, and we really appreciate all the advice and answers that you have provided us.
And thank you all for your patience and understanding so I could get my patient seen. Thank you so much.
Absolutely.
Best of luck, everybody.
Thank you. Have a great day.
Thank you.